My name is Teele Kuusk. I'm a urologist, and I work in this lovely hospital in Dartford Valley, which is overlooking London. And of course, my passion is renal cancer and lymphatic drainage, more specifically, for which I just defended my dissertation a week ago. I have no disclosures. So when Patricia talked you about renal cancers or small renal masses, which were less than 4 centimeters, then my talk is about renal masses which are more than 4 centimeters in size and confined to the kidney, can be even more than 10 centimeters. So in a T classification, it will include tumors T1b to T2b. And my talk is divided into 3 parts. First of all, I would like to show you the highest evidence we have today about radical nephrectomy and partial nephrectomy in these tumors. Then I would like to talk about differences between open laparoscopic and robot-assisted approaches and what kind of evidence we have there. And finally, I briefly speak about a lymph node dissection in these tumors. Unfortunately, we don't have a very high evidence in surgery in general. However, we have prospective randomized study by EORTC group published in 2011, which included patients randomized to radical nephrectomy or partial nephrectomy up to 5 centimeters in size. This was the first prospective randomized study performed so far with radical nephrectomy and partial nephrectomy. And as we see here, in intention to treat population, there was a slight difference in overall survival with radical nephrectomy and partial nephrectomy. In 10 years, radical nephrectomy patients survived 81% and partial nephrectomy 25%. However, in targeted population, actually the difference disappeared, and statistically these groups were very, very similar. So to conclude from this study, we see that partial nephrectomy and radical nephrectomy are comparable regarding cancer-specific survival. However, there's a slight higher risk of ESKD after radical nephrectomy. Another evidence we have to treat surgically T1b and also T2 tumors come from a systematic review published 2017 by Miss Meir. However, this systematic review was extremely biased regarding the group of patients, their comorbidities, their age, so the groups of patients were really heterogenic. However, what we see here to conclude is that actually in these retrospective studies, which this systematic review included, a partial nephrectomy group had a longer median overall survivor and also cancer-specific survival favoring partial nephrectomy. They made another subgroup analysis with only T2 tumors, showing that cancer-specific mortality was favoring partial nephrectomy, and also tumor recurrence was favored with partial nephrectomy. But I repeat that this patient group was really heterogeneous. About morbidity with these different approaches, this evidence come from the prospective randomized study by Poppel, which shows that actually morbidity or complication rate is quite similar with radical nephrectomy and partial nephrectomy regarding tumors up to 5 centimeters, which this study included. However, as expected, when we go to larger tumors, T2 tumors, then we see approximately 2 times higher risk of complications with partial nephrectomy compared to radical nephrectomy. Regarding complications, also in Mears systematic review, we can see here that it favors radical nephrectomy. Also, blood loss is less with radical nephrectomy. This is also slide from Mears study systematic review, which also looked at kidney failure after these different surgical treatment options, and of course, like expected, it favors partial nephrectomy. Regarding different approaches, open versus laparoscopic versus robotic radical nephrectomy, we have very many publications. However, these are all retrospective studies and some systematic reviews and comparative ones, but we don't have any prospective evidence which approach would be better. And all the older studies, of course, are more with radical nephrectomy open than mini-invasive ones. But the evidence we have now from the retrospective studies and comparative ones, we see that regarding radical nephrectomy, laparoscopic one have a shorter hospital stay compared to open, and lower analgesic requirements, and also shorter recovery periods. When we compare partial nephrectomy, different approaches, laparoscopic, robotic, and open one, then also the evidence is really really low. But what we know so far is that a robotic approach will have lower blood loss and shorter hospital stay, and some studies, comparative ones, also having less complications. Another prospective randomized study in renal tumors are about lymph node dissection, published 2009 by Blom, where radical nephrectomy with and without lymph node dissection was compared. These were cases with clinically N0 disease, meaning that on imaging there were no lymph nodes, lymphadenopathy. However, this study was also underpowered, and they finally had a rate of lymph nodes positive disease only 4%. So not surprisingly, they didn't find any kind of difference with survival between lymphadenectomy and without it. Also, a systematic review performed with all retrospective studies showed the same kind of outcome. The reasons why a lymph node dissection in kidney cancer has not proven any advantage in survival are manifolds. But there are some points I would like to remind. One could be, of course, biology. Kidney cancer is biologically very diverse disease, so there are just some tumors which are more aggressive than the others and behave more differently than the others. But also there's a question about lymphatic drainage, and as we saw in our prospective study performed with SPECT-CT, where we were looking at lymphatic drainage in kidney tumors, we saw that drainage is very variable and individual, and only 65% were draining inside these lymphatic lymph node dissection templates, and 35% of drainage went initially outside of these templates, and from this 20% is also going to thoracic area. And as we know, thoracic or lung metastases are one of the most common metastases in kidney cancer. So this could be also one of the drainage pathways and why these metastases happen. To conclude my talk, I would like to say that we need always personalized approach, whether the patient would benefit of more kidney function saving, or whether more important is just oncological outcome or complications, to avoid complications. So these are the discussion points which we need always to go through with our patients. and consider in every individual patient. Thank you so much for your attention, and good luck with your training.